Okay, we're going to get started. I hope these two folks will actually show up in a few minutes, but they were at the last training, so I'm good with that. So the next thing we're going to do is we're going to start to walk our way through some of these other areas on the left-hand side here in the quick list, just so you can kind of see what's in there. Now, one of the questions that just came up was, how do you assign a population, right, especially in the WIO data set? Typically, populations in the tool itself, now hold that thought for a second, the tool itself can be assigned two different ways. We can either take an assignment of a panel to a set of providers, or we can impute whether or not that provider is actually has a panel of patients based on the claims that are coming in. WIO does the imputation methodology, so we don't get assignments. And the way the tool works is it says if it's imputed, if not assigned. So imputed if not assigned. Now, how does imputation work, since that's the way you guys are using it? Imputation essentially looks at and determines, number one, are you a PCP or capable of being a PCP? So folks like internal med, folks like pediatrics, family practice, those folks are PCPs. So the next question is, what kind of a panel do they have? Who's on their particular panel? So what we do is we go through all the claims, and we look at the claims, and we look at the doctors that submitted the claims, and to simplify a 7-page paper, which you guys all have access to on the WIO Hub, to simplify a 7-page paper, we look at the E&M claims primarily, and we say, who's got the preponderance of the E&M claims? And then we say, okay, are we going to assign this by who's got the most dollars, or who saw the patient last? And that's how we actually impute who goes to which doctor. So if you saw 3 PCPs over the space of a year, but you saw one of them 5 times and the others like a couple times, the one that you saw 5 times would probably be imputed as your PCP. Unless you selected the option, and this is in the configuration workbook, which says, no, the last one I saw. Now, this sometimes gets confusing because within a group of PCPs, like say a family practice, you might have 5 or 6 PCPs, right? And if you go there, you don't necessarily see your PCP if you're going on a visit. So sometimes it's applicable at the group level, and you can actually see that when you actually come down because you have your affiliation sitting in there. Other times it will definitely be at that individual level itself. So that's how we do imputation. And when you look at, and I called up, this is the WIO instance here, and what I did was I actually called up the population instance. So here's family, and it says based on population. You can see that there's no episodes involved at all. You're on the demo system, so you won't see it this way. So there's nothing here at all. If we come over to here, all of a sudden we see the population, and we see the population morbidity. Well, population morbidity is a little bit different than episode risk, right? Population morbidity simply means I've got this panel of patients, and this is how sick they are or not sick they are. So if I see a 0.76 out here, this tells me that the panel of patients, 402 of them, that particular provider has in this particular peer definition is 24% less sick than the average, 1.0 being the average again. If we come down a little ways, all right, 47 patients here, they're 2.5 times, or 2.27 times sicker than the average. Well, what does that mean? The expectation is they're higher cost. The expectation here means they're lower cost. So when you start to compute the indexes, like the quality index or the index for the population, which of course, and I'm going to ask you the question, how would I add in the population index here if I wanted to? If I wanted to add another column here that said population index, like I have quality index and episode index, right, exactly. You go up to the columns button, you'd add it in, and then you'd get rid of the 3 that you don't want here, right? So essentially you set these up so that you have the data you want there, and the rest of the data is like missing, and then you sort it the way you want it, and then you save it after that. That's kind of the way in which all of these reports work. Then, as you publish a new data set, which is done twice a year for WIO, all you really need to do is go up to My Reports, re-click that same report, and it's going to use all the new data from the new data set, and it's going to pop that new report up. And remember though, that old data is gone from that old report. So if you had a report like this, you ran it today, right? And you didn't save it anywhere, it's just there, right? Don't expect to go up to there to My Reports after they publish the new data set and get the same report out. It's never going to happen. What many clients will do if they want to keep that history is they'll take this report, they'll export the data to Excel, they'll put it in tab 1 and say, this is January's run. Poof. Then they'll do July's run, and then they'll keep on moving like that. Now that's extremely valuable if you're doing something like trending. So for example, if you wanted to trend the morbidity of all of your patients over time, you could get that retrospective risk score or that prospective risk score, and you could keep track of that. You could keep track of it by region if you wanted to. You could keep track of it by provider if you wanted to. As you can see, we have it by provider here. So anything that you can think of that you want to trend, one of the things that I look at when I look at reports is, why do I want to trend it? Of what importance is it? So let me give you an example. If I'm, and I'm going to give you an employer example, which really doesn't apply here, but employer groups like to know why their premiums are going up, right? So if I have a trend of all of the employees that this employer group has had over time, and I can show that the risk scores have been going up over time, that's a really good reason to walk into the employer group and say, hey, you went up 7% because your risk went up 8%, right? If you want to look at your Medicaid population in this particular state, and you want to say, hey, is the Medicaid population getting sicker or is leveling off? You can do that by using a trend report. The application only contains 27 months worth of data. That's not a lot to do trending. That's why you actually use that and save every cut of that into a spreadsheet. Now, the application can handle up to 10 years of data. Right now, we're not putting 10 years of data into this. I only have one client that does 5 years of data. So most clients aren't going that high. Yes, ma'am.
So you said on some of these, when it's underlined in bold, you can click into
Yep.
the details. When you do that and want to go back, how do you go back?
Two ways of going back. First is, the normal back button on a browser, right? And then occasionally you're going to see a little, like a little circular thing right in here. If that's there, that's a better way of going back because it remembers what's happening, right? In some cases you don't need to, so it's not there. But there's two ways of doing it, and if I get to one, let me see how I can show you that. Yeah, I'll get to one of those when I get down to cost and use here, and I'll show you that little back arrow thing. Okay, so the next thing we're going to do is we're going to use the demo system, and we're going to just actually go directly into the members. So you can follow along, and I'm going to click the members tab here. And you can see that we have a number of filters that now apply to members specifically. In this case here, we've got the general tab where you can throw a member ID in. You can throw how much money the member has spent, how many quality opportunities they wanted, how sick the member is, how many inpatient days they had, et cetera, et cetera. Next one is by employer, by age category, by geography, quality compliance, or quality non-compliance. A lot of the clients will use this particular list and go into quality non-compliance and say, find me all the members that are non-compliant with X. So that's what we're going to do right now. And we're going to see all of the rules that are available to you. So I'm going to go into quality non-compliance, and you guys can follow along. And under quality non-compliance, what I've got is I've got a list right in here of all the quality conditions as applicable to certain specialties, right? So if I were to click cardiology, I'm going to get a list of rules under cardiology. Gastroenterology, a list of rules under that. So what I'm going to do is I'm going to go under cardiology first. And under cardiology, you can see I've got folders. Anything that says NS after it that you see up there means national standards. Anything that doesn't say NS means it's either an NGENX standard or we've worked with some societies to actually identify quality measures that make sense. So I'm going to go into CHF and open that up as the national standard. And here, one of the things you need to pay attention to is, do you have the data to support whatever you're checking off? So in this case, patients prescribed an ACE inhibitor during the measurement year. Second one is patients with CHF currently taking warfarin. What do both of those rules require in order to meet? Pharmacy. Absolutely. Absolutely. Now, you guys are putting pharmacy in. So if you have that information, I'm going to just say, I want to find all the patients with CHF currently taking warfarin, right? But what I'm doing here is they're not compliant with this rule. So in other words, they're supposed to be, but they're not. And what I'm going to do is just go down here and I'm going to submit it, and it's going to produce a list of all of those patients for me. Now, depending on what you're looking at, it can take a little bit of time to pop the list, or it can take a long time. If you go into the claims list with your 247 million claims that you have, and you ask for every one of them, it's going to take a very long time to produce that. So what I would do is I'd be very judicious when I attack the larger lists like claims and like members, and actually fine-tune that with the filters. So in this case here, we've got 36 rows shown at the top here, and all of these patients in here, all these member IDs here, are missing that particular item under quality. Now, one of the things we can put in here, if we go into columns, is we can say, well, is this applied to one or more or a few patients as well as physicians? So as you work your way down into here, you can see all the different things that you can put in. I can actually put in an imputed PCP name since we're doing imputation. You guys should be able to do the same in your instance of this. So if I put that in and I submit that for the 36, the same 36 show up, but I've got the PCP there. You can sort it by PCP and say, hey, is there one or two PCPs in my network that aren't getting this done for their patients? Okay, so there's the list. If I go to the far right, there's the provider, imputed PCP name, and you guys will actually have a name there. And if I sort that, we'll be able to see who's the biggest offender of that. So there's my list, and you can see that provider 34's got at least a couple cases here, provider 59's got a couple cases, etc. So this is one way to kind of look at your data, and it's one way to say, okay, is the provider actually doing on a population level what he should be doing in terms of getting the patients to be compliant with that? Now, a neat slice of this data, right? You know that populations are different just because of the types of people that are in those populations. So for example, if you've got a provider and they've got a population and they treat mainly commercial, and the commercial payers have a really good plan, low co-pays, sometimes you get a difference in quality just because of that, because the patients are very compliant, they get done what they need to get done. If you've got a Medicaid population, I've seen this across the United States now, in every Medicaid population, it's much, much lower than the commercial. Even though they have the lowest copay, right, they simply don't do what they're supposed to do. And so that's a reason for looking at it, and you're doing a pay for performance with a physician, you may want to slice the data by product. Hey, they're doing really great over here, they're not doing so good over here, but there's a good reason for that. And maybe there's some intervention you can do. Maybe the population they're dealing with, the Medicaid population, needs transportation. Maybe they need phone. Maybe they need the availability to get somewhere. Maybe they need babysitting. But there's all sorts of interventions you can do, and by slicing the data differently and finding the different quality measures, you can actually home in on those that are most applicable to saving you guys money in the long run and get those taken care of. So that's the member quick list. If we go down to the episodes quick list.
Can I ask a question about
Absolutely.
that? For each member ID, there's a number of compliance and number of quality opportunities.
Yep.
So these folks are non-compliant for at least one.
That one that we picked, right.
Oh, so those compliant and non-compliant opportunities, those are just all opportunities.
That's correct.
With all the
Yep. So what he's referring to is, as you, and I got rid of it, but as we were going across there, it showed the member ID, and it showed, say, 5, and you were compliant with 3 of them, and the percentage was X. Well, the 5 included the one that we picked, but that member had other issues as well. So that's everything that member had. And if you were to fine-tune the list, you could actually fine-tune it by, hey, what's the member that has the least number of compliant measures, if you wanted to do it that way. The other neat thing to do about this, and quite frankly, because your members are masked in WEO, you can't really do anything at the member level, right? So you're really looking, that's why I put providers up there, you're really looking at the providers. What can you do in that particular area? Clients that have unmasked members typically use the list and actually go directly to the members and try to get things done. They also take those lists and they say, sort that list by who's my sickest member to who's my least sickest member, and let's go take some action on that as well. You guys can't do that because everything's masked and you can't see the actual who the member is. Okay, so for episodes again has a number of filters at the top, and one of those filters happens to be ETGs. Now, all this is going to do is give you a list of the episodes. So if I were to pick, in this case here, I'm going to pick endo, and I'm going to come down, and I'm going to try to find diabetes. There it is. And if I open up diabetes, I've got diabetes without surgery and I've got diabetes with surgery. And the reason I opened this one up is because I wanted to show folks that we get it right down to the severity level or the severity of the condition. So it's not just you have diabetes. How bad is your diabetes? So we actually take that, and diabetes has 4 specific severity levels. 4 being the worst diabetic, 1 being probably an in-control diabetic that's going along, but they're okay. All of these, as you click into them, will have 1, 2, 3, or 4 levels of severity. They don't all have 4. Some have 1, some have 2, etc. And you can actually select only those. Let's say, for example, diabetes severity level 4, Sarah. Just select that.
How do you know what those definitions are? Is that listed somewhere?
Absolutely. I'm assuming on the hub, we have the spreadsheet that lists all 984 ETGs. And within each of those ETGs, you'll see whether or not it has 1, 2, 3, or 4 severity levels. Now, by definition, is that what you meant?
Right.
Okay. Because if you want to know how we define diabetes per se, that's a different topic.
Do you want to talk about the differences in severity levels and how they are determined?
Yep. Oh, okay, we can talk about that. In fact, I have a slide to show that. So if you just let me zip in here. Yeah, that'd be better. Thank you. And bear with me while I find it. Did I just pass it? Yeah, there we go. Okay. I don't want to use that one though. There's a better one. This is the better one. Okay, so how do we define severity levels, right? In this particular case here, we have ischemic heart disease as the thing. This has some complications, some comorbidities, and some treatment that's associated with that. Well, for each one of these, in terms of calculating severity, the complication of AMI gets a number, a severity weight of 3.4. Now, how did we determine those numbers over there? We have a very large 95 million member population that we draw from our benchmark population, and those are resource utilization numbers. So in our huge benchmark population, we found everybody that's got AMI, and we said, what's the resource utilization of that? And we gave it a number, 3.4. As compared to morbid obesity, which only has a 0.4. So it's relative resource use within each one of those categories. And because this particular individual has an AMI, obesity, diabetes, depression, and happens to be a male 45 to 50, his number, his severity, adds up to 6.8. Then what we do is we put it on a severity level scale. Go ahead.
Is this like your risk adjustment?
Yes.
Scores? Is that what that?
This is part of our risk adjustment.
So severity level, because I'm,
Yep.
so at severity level, when you're talking about diabetic, in my mind, I'm thinking severity A1C greater than 10.
Mm-hmm.
You know, versus how you are defining it, your highest severity is actually your highest comorbid patients. That's what I'm understanding you saying? So your level 4 severity level for diabetes is somebody that might have diabetes, AMI, CHF, is that?
If it's the diabetic episode, they have those comorbidities.
They have those comorbidities.
Yes.
That's your
Correct.
definition of
Now,
severity.
the A1C level is a lab value, and lab values do not play into this because you guys aren't using lab values whatsoever.
So, Paul, building on that, if we had lab values, would the severity be a combination of the presence of different comorbidities in addition to the extent of that comorbidity?
Okay, so the question is, if we had lab values, would that play into the equation at all? In iPro, it would play into the equation. In II, it does not play into the equation. And you guys do not have iPro. iPro is a different tool at the member level, and it computes risk differently. It also computes risk better. Many actuaries use iPro specifically to do underwriting. So it's a much better tool. This tool is designed as a retrospective look, population, right? Population-based, provider-based. That's what it's designed for. It's not designed to go down to the member level and actually assign a really great prospective risk.
So that raises a question about a new member for which you don't have a lot of past data.
Bingo.
In which case you can't really calculate.
Well, the only thing that happens is this male 45 to 50, the age sex, gets popped in, and that's what gets used. Which is, in the old days, that's all actuaries had anyway, right? And as claims start to build up, either pharmacy claims, which build up fairly rapidly, or medical claims, then we kind of add to the mix. What many folks will do, and you guys and we are slightly different, but what many folks will do if they have pharmacy data coming in, they'll actually run the tool on a monthly basis to capture all that pharmacy data, because you can find out a lot from just pharmacy data. And in fact, many folks will use pharmacy data to actually put people into case management, disease management programs without having one shred of medical claim coming in. But you guys are slightly different. You run twice a year. The tool's not being used that way for WIO. They're not being used to identify members to do anything with. So, and then what we do is after you get the number, basically the number gets put into a level, and then wherever it falls is where it hits. Now, how do we use these? Well, we can't really use this if we're comparing Dr. A to severity adjust Dr. B, right? Because those numbers are continuous, right? So what we do is we put them in buckets. And what we do is we say, okay, Dr. A is a cardiologist and has treated 30 cases of hypertension. He's got 10 cases of hypertension, severity 1, 10 severity level 2, 5, and 5. Then what we do is we say, okay, for all of those cases at those severity levels, what's his actual cost? Well, he's got a real cost sitting in there. It's our standard cost. Boom, $30,000, right? Then what we do is we find all the cases of hypertension out there, right? So it's not 30 anymore, it's 30,000 cases, right? And then we say, okay, well, what's the average cost or expected cost for the ones? What's the expected cost for the 2s and the 3s and the 4s? And then we use that expected average cost for all of his peers, and we say, how does his actual cost compare to the expected? So actual divided by expected gives you an index value. And then there's one more twist to it. I know I'm making it complicated, but there's one more twist to it to make it accurate. What we do is we look at each of those costs and we say, how responsible is the physician for portions of that cost? So let's say for hypertension, you might go to the ER, you might have an inpatient stay, you might have outpatient associated with it, you might have lab, you might have RX. There's 7 categories we call profile service categories, and we weight each one of those. So if you're a cardiologist, you'll have a very high weight on the inpatient because you're likely to send that person to the inpatient. But you have a very low weight on ER because you're not likely to, the patient just goes to the ER, right? Doesn't talk to the doc. So the actual and expected get adjusted by the percentages as well. So it's a really fine-tuned application to being able to say Dr. A is risk adjusted against Dr. B so we can compare the two equally. Because otherwise what would happen is Dr. A could be seeing only type 1, Dr. B could be seeing only type, and we could be comparing them and they'd be saying, no, my patients are sicker. Remember that old adage? They all have the sickest patients. Well, you can't do that here. Not available because we're taking care of that. Does that explain risk a little better? Any other questions on, oh, go ahead.
Very quick question. Category 4, level 4,
Yep.
6.1 and above.
Yep,
Does it have any ceiling?
it does not.
It does not. Have you found any distribution which says most patients tend to be around 7, so if somebody has a score of 15, that skews the costs? Or?
We actually use standard statistical methods to get rid of outliers,
Okay.
so we don't get to that problem. And on the low side, for the low outliers, we tend to just drop them, get rid of them, right? On the high side, we truncate at a certain point.
Well, you have a truncation at 0 anyway.
Yeah,
so
yeah.
You don't need to worry about it.
Well, but sometimes, in some cases, the truncation points apply at the episode dollar level as well,
Yeah.
not just the severity level.
Yeah. Thank you.
Let's see. Okay, so let's talk about finding all my severe. Whoops, what did I do? I don't know what I did. But let's talk about finding all of our severity level 4s for endocrinology. So if we were to click on that and we were to go down to find diabetes, and we were to do diabetes without surgery, and we were to click right here, severity level 4, we could then actually just go in and submit that, and what it's going to do is it's going to go bring up all of my severity level 4 episodes of diabetes. And you're going to be able to see how many episodes there are. Now, there's certain types of episodes that we call chronic episodes, right? They're year-long episodes. So if you're a person that has diabetes, you have a single chronic episode of diabetes for that entire year. There are other episodes. Did I submit that, Sarah?
It's thinking, yeah.
It's thinking, okay. There are other episodes that are called acute. So for example, I can have pharyngitis 4 or 5 times a year, right? So an individual can have 4 or 5 episodes of pharyngitis. Now when you're starting to look at data and you're starting to identify whether or not quality measures are followed or quality measures are not followed, or how sick the patient is, you have to consider if it's an acute versus a chronic episode, right? Because if it's a chronic episode, let's say it's pharyngitis, or let's say you're going for a sore throat to your physician's office. Well, one of the first thoughts in the physician's office is, oh, sore throat, it might be strep, right? So if you do that 4 times a year, you actually qualify for the strep throat quality measure 4 times. So you could see that show up 4 times. And that's not a mistake. That's true, because he should have done a strep test before handing out an antibiotic. If they didn't do it, he's non-compliant 4 times. But that's all on the patient. So the doctor gets all 4 of those. Whereas if it's a chronic condition like diabetes and it's an A1C test twice a year, well, it's twice a year, that's all it is. Too bad, it's twice a year. So that way the doctor only gets hit twice. So it's not like we continue to count every time somebody goes in for a diabetic encounter, if you will. So here, what we have is all the episodes. And in this case here, we got 1,013 in the data set. And one of the things I didn't mention, but I should mention, is right up here at the top, right next to the Save button, you'll always see everything you've done to filter it. So when you go to save this report or print this report, you're going to know exactly what went into this. In this case, the only thing I did was diabetes without surgery, severity level 4, and I also had it in the date range between 1/1/2010 and 12/31/2010. But if you added 5 or 6 categories, this list just builds and builds and builds, so you always see what you're going to be filtering by. So next month when you go in there, you don't have to wonder, you don't have to go fishing for it, it's sitting right up there. And once again, as this came out, any of these columns can be sorted, high to low, low to high. You can get rid of columns that you don't like, you can add columns that you do like. Sir, ma'am, I'm sorry.
Is there any way to view the SQL for what you've already done and work from there as opposed to starting off with, we have the SQL tab, but you have to start from scratch to use that, or can you be at any point in the process?
You cannot view the SQL that it creates. It creates the SQL on the fly when it runs the report, so you can't see it. And by SQL, the SQL tab, that is only the where clause of the SQL. That is it. So in other words, you know how you say select star from blah, 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 where? It's only the where clause that you type in. If you try to say select star from blah, 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 it's going to ignore you. You got to say where and then pick out the fields that you want and what they're equal to or what they're like, and then it'll run. So you can try that, anytime you want, and if you have any issues with it, let us know. It is kind of funky SQL the way we call it, but it is only the where clause. And the reason for that is because we already know the table it's coming from, and we already know all the columns you're allowed to put out. So you can't just pick and choose what you want in that particular SQL statement. You can just filter. It's a filter statement, essentially. Other questions? Yes, sir.
If you're drilling in the data and you've made some sort of a monster, does it say to you, do you know that this is huge before it runs it, or you're just gonna watch the clock? Okay.
Yeah, just gotta watch.
It doesn't warn you that
Nope.
it exceeds 10,000 or.
Yeah. So the question is, if you build a monster query and it's going to bring back, 200 million rows, does it warn you? The answer is no. There is a timeout associated with it.
You may never see it.
Yeah, you may never see it. Exactly. Exactly. So that's why I said before, when you're doing things with your claims set, 247 million claim, don't just go submit, but really fine tune it. Maybe the date range is what you're looking for. Even if you put in something like, I want to see all my 99212 codes. General office visit, that's going to take forever to run because there's a zillion of them.
Actually, that must be an indexed field because
Oh, okay.
it'll return
That's faster?
a single CPT code very quickly.
Okay, that might be an index field then.
What is the timeout on ours?
20 minutes, I think.
Yeah.
Can you abort it if you hit submit and said, oh, I
Mm-mm.
submitted?
No, it's running on the server.
Okay.
You're right. Now, here's the thing. With all you folks going in and using the data, right?
Yeah.
If 3 or 4 of you are doing these monstrous queries, everybody else slows down to a crawl while those monstrous queries are running. So something to think about. You might want to say if you're going to run a really large query, maybe just before you go home, 5:30, 6 o'clock, you just punch the button and walk away. That's the only thing I can suggest.
But that'll time you out. The web
At
browser
20 it will,
The web
yeah.
session will time you out. So,
Yeah.
so don't do what he just said.
Yeah, don't do what I just said. Yeah, you guys have a short one, yeah.
Yeah.
So sometimes, we have clients that have very long timeouts and actually do that. That's why I
Yeah,
brought it up.
yeah,
Sorry
yeah,
about that, I
yeah.
forgot about that. Okay, so now, we've kind of gone through a lot of the quick list area here. We've talked about members, we hit episodes, we definitely hit claims. We haven't done quality, cost, and use, or confinements yet. Confinements is one of those things you're going to see in the new product as it comes out in December. And Sarah, why don't you just click on confinements? And what confinements is going to do is it's going to allow you to see an inpatient stay as one line. What does that mean? It means if you went in on December 1st and you got discharged on December 15th, everything that happened between December 1st and December 15th get compacted up and put on one line. It's a confinement. That's different than an inpatient stay, which you can see your claims and you can see actually every single line that goes into that particular claim. So again, when you're looking at confinements, you get that filtering thing, and one of the neat things here is DRGs. So you can filter it by DRG. So if you wanted to filter and say, I only want to see my cardiac DRGs, you could start clicking into here, and you could pick whichever one you wanted. Now, this is being the demo system, has a lot of different ones. We got MS, we got CMS, we got AP, but you could pick any one of those, and you could actually find every one of those confinements. Or if you just wanted to look at confinements and see what it is, you just hit the submit button down at the bottom, and it's going to bring up all the confinements. And then you can decide how to sort it, what columns to put in. But this works exactly the same way as any of the other quick lists. You have the columns, the filter button, claims for each confinement are shown here. So in this case here, this particular patient had a start of service on 4, they were discharged on 12. It was a mental health type of an admit. There's the diagnosis code. If I clicked over here, the claims, I would get all the claims associated with that confinement. And that's on the new version in December, so that's what you'd get. And then if you clicked on the member ID, you're going to get member information because it's going to drag you right back to the member list here.
I clicked on claims, sorry.
I don't care which one you clicked on. It's fine. So here's all the claims that particularly made up that particular stay. And again, columns here, you can change it or you can move to the right and you can see what was happening there. You have some poisoning and some, depression? Yeah.
And that member ID is the one that you guys assign?
Yes, correct. And you can't track it back to your members at all. Now, but you can go back one, Sarah. You can actually go in here and you can actually see who the provider is, and if you wanted to actually put the facility name in there, facility name would be a column that you could go back, to the columns button, poof, put facility name in on that. Now let's go down into quality, because quality is a pretty interesting one. And quality actually gives you, if you look across the top here, some of the same stuff you've seen before, but again, you can decide what you want to do by quality rule, by quality type, etc. I generally just say submit the whole thing because I want to get a picture, a snapshot of what's happening in the enterprise. Now, quality sometimes is, again, could be fast, could be slow, depends on who's using the system. Sarah's clicked it and we'll see how fast it is. But as we go here, one of the things you'll want to do with quality is really start to subdivide quality, maybe by product, maybe by region, maybe by affiliation. And you can do all of that within the columns itself. You just add extra columns and it's going to subdivide the quality out for you. When it first comes up, it just brings every bit of the quality in there. And in the class on Tuesday, was it Tuesday? Yeah, on the class on Tuesday, what was interesting was somebody came up with the idea that, hey, why can't I take my quality and look at it by PCP or imputed PCP? Well, that's an available field for you too. So you could slice it that way as well. So really, if you can think of what you want to do and come into the system, a couple of ways of doing it. Look at the filters first. Can I filter it that way? Well, if the filters don't do it, the next thing to think about is, how do I set my columns up so they actually will do it? Because just because I've got everything coming up here doesn't mean that I'm going to have all of the columns showing. I could add or subtract columns. And in this case, I think because it's taking so long, the rules are probably going to show up, which is the lowest level, and there's a ton of rules. So what I usually do is collapse it to the clinical conditions, like cardiology, endocrinology, and then I start uncollapsing from there. So there's a lot of different ways of hitting that. I don't know if we're going to wait for that or not, Sarah. Oh, how about drop into your the other one and do it on yours, yeah.
Or you want me to just submit?
Yeah, just a minute. See if yours is any faster. Ha! There we go. I'm liking that. The demo system is actually used by other folks besides me. I was really supposed to use this system, but in any event, so this is sliced clinical condition case. So if I want to collapse this even further, I'd go up to columns, and this gives you a snapshot of WEO as a whole, and I'd get rid of that case. Yep. And then I'd go ahead and resubmit that. And now it's going to make a liar of me and take forever. Oh, there we go. So now it's a nice short list. And at this highest possible level, you can see that both the compliance rate and the health plan rate are identical. Why? Because it's the entire population. Everything's thrown in there. Then you can come across each one of these measures here, and you can say, well, which one's really low? What do I have to really work on here? Well, you've got this one down here, preventative and administrative. Well, forget that one. I don't like that one. 52% at the top, cardiology. We could actually drill into cardiology now by just setting the filter for just cardiology and identifying those rules which we're really low on. So if we set the filters for just cardiology, yep. Yep.
And here's where I would strongly suggest going to the custom field
Mm-hmm.
and checking on full claims. Don't want to include anyone in the denominator that didn't have
Full claims.
full claims.
And that would be your Medicare Advantage folks that have a subset of claims. And are there any others besides that?
There are some out-of-state members
Yep.
that get submitted that we don't have all of their claims.
Mm-hmm.
Or dual eligibles in Medicaid.
I'm sorry?
Dual eligibles in Medicaid.
Dual eligibles in Medicaid.
Yep.
So now, because I've got just cardiology up there, I'm going to fine tune this a little bit, and I'm going to go into columns, and I'm going to start adding, because I want to see which area it is, I'm going to add case back in. And then and Sarah's going to bring it up to the top. I didn't show you this before, but these little buttons here, these little arrows, allow you to move things or the order in which they appear. So you can move them up or you can move them down. You can click it, it'll move it once, or you can click and hold the mouse and drag it up. Okay, so now I've got all the cardiology by case, and if I come over here, I see I've got this really low one down here. The national standard, 3%. Wow, that's pathetic. What's going on with that one? So now what I do is I go back to my filter and only select CHF. Right? We're going to unclick the main one, go to the CHF one, which is the national standard one we want. Yep, that one. Just select that one. Submit that. I'm going to get that one line, and then I'm going to add the rules underneath that in there. And again, you can see it's building right at the top right up here. So yep, Sarah's going to go over to there. We're going to add rules. Yep. And we're going to run it. And we're going to say, okay, which one is really bad? Or what's driving this? Okay, so if we go to the right a little bit, we can see that there's a bunch driving it. And we can actually see why already. But go ahead up. You can see a bunch of zeros in there. So you've got 56% here, 9%, 44. So these zeros here are driving it. This 0.09, that's nothing. There's only a few in here. But these zeros are what's really driving it. And take a look at what it requires. In this case here, assessment of activity level within the measurement year, assessment of symptoms, blah, blah, blah. So all of these here are not necessarily claims measures. You need to get those somehow else. So these are rules that you wouldn't want to gig a physician with at this point, right?
And the provider measurement, the P&A quality rules do not include any of these
Right.
zero compliance measures.
So then is there a way to filter this out?
Absolutely. You don't have to have the application in the configuration. You can say, never look at EBM quality measures X, Y, and Z for any peer group. Absolutely. And have we done that
I'm sorry, say that again?
in the configuration where you select by peer group which quality measures get counted?
Uh-huh.
Have we got the ones that you don't have data to support unXed?
Yes.
Yes. Okay, so yeah, it's already taken care of then.
Well, in the quality quick list though,
Right.
there's no.
Oh, there's no
automatic-
filter on that, no.
Right, so
No.
you have to,
Use the filter button up here to do that. Yeah, when you're measuring physicians though, it's been taken care of. Yes, sir.
In the way we measure quality, since we don't get lab data, is anything that's related to labs then not?
that's not included either,
That's
in
not
provider
included.
measurement.
Okay.
Yep. If you think about the configuration workbook, and I'll try to bring it up right after lunch. Essentially what it has is it has all of the peer groups that we saw before right across the top, one in each column. And then coming down the left-hand side, it's got every single measure, all 584. So at the rule level right here. And what happens is when we set the application up, you go and put an X wherever you want it to count for whatever peer group you want it to count in, and it uses it. If you don't put an X there, it doesn't get used. And the same thing applies to episodes, big grid. So a lot of work was done by WEO early on and continuing to actually fine-tune that particular grid. In fact, the latest population groups and stuff, you guys just worked on that over the last year, I think, to
Right.
add those in there.
Right. And one change that you'll see in Data Mart 10 is that we've removed the flu vaccination quality measure from all of the primary care peer groups.
Mhm.
It's a huge volume quality measure.
Yep.
And because of how people get their flu shots, there's not always a record of it in the claim.
Exactly.
And so it's an artificially low compliance. So we removed that measure altogether from the peer definitions.
Mhm.
You can still get at it through the quality
Right
group
here.
list.
Okay. Okay, let's see, is there anything else I wanted to do here? No. So let's go to cost and use. Now, cost and use is one of those exploding menus.
Wanna go back to demo?
Oh, sure, we can go back to demo, yeah. Sorry about that. Cost and use is one of those exploding menus here. And cost and use explodes out to aggregate, trend, whoops,
Sorry.
that's okay. Aggregate, trend, type of service, specialty facility, and pharmacy. So if you want a snapshot of something and you want to look at a quick utilization per thousand for anything, all you'd have to do is do the aggregate, and you can do it on the population or the episodes. Well, what's the difference? The population is everybody. Episodes are only those episodes that got created. So if I do aggregate population here, what it's going to do is it's going to pop up, again, the same kind of thing you've seen before, and you can actually start to filter this. Now here's where we're going to actually do a mistake to show you what happens when you do a mistake. If I just submit this right now, it's going to bark at me. It's going to say, oops, you forgot something. And it's always going to put it down in here, and you must select the time period. So in this case here, you can't just select everything. You have to pick the time period you want. So if Sarah goes to time period, we can actually select which periods we want to include here. And you can pick either current or prior, I don't care. Yep. And now we can select it. And it's going to come up with a set of statistics that define the population cut that you're interested in. Now, in this particular case here, in the WEO instance, one of the cuts might be region. That's a great way to look at your data in terms of statistics. So what's the MRI rate per thousand up here versus down here in Wisconsin? You also might be able to slice it a lot of different ways. And we'll go over to your app in a second to kind of show you the different ways you guys could determine to slice it. But again, as you're looking at the top here, these are just the filter conditions. The slices, if you will, actually can come in by adding those extra columns in. Somebody's actually using our demo system. So why don't we just go to yours?
All of these guys.
All of these guys, I know, yeah. It's just taking forever. So let's just use yours. We'll do cost, yep, aggregate, population.
Now,
Pick-
to reinforce, this concept of the funnel,
Yep.
this is all 247 million claim lines.
Mhm.
It's 66 point something billion dollars in billed charges.
Yep.
And this is the place where you would go to look at everything in an episode, not in an episode, et cetera.
Mm-hmm.
So this is slow too.
A lot of students using the internet right now? I don't know. That's interesting. Well, while that's running, let's see. What if we go back to this? Oh, there we go. Okay.
You're back on the.
I'm back on the other one, that's fine. So in this case here, and yours shows the same thing. It basically, the default is by age group in here. You get your member months, you get your amount allowed, you get your PMs, and then going across, you're going to get a variety of statistics here. You got your inpatient admits per thousand, days per thousand, length of stay, encounters, etc. So at a very high level, you can actually see what the enterprise, or WEO in this case, is doing. In any of these data sets, these age groups here are fixed and they're part of the Optum age groups. Yes, ma'am. Yes, encounters per thousand.
And then the costs, sometimes it's PM.
Per member per month, right. So what do you mean some, I get the sometimes, it's always PM. If we're looking at that, we don't do PMPY, if that's what you're referring
In the
to.
population view.
Right. So in this case here, that's one slant, and I guess that's kind of an interesting slant, right? But if you were to go over to the columns here, there's a lot of other things that you can do to actually sort this differently. And I didn't really filter anything. All I'm doing is going off to the columns area, and I'm going to reselect, probably deselect the age group and select something that's more interesting, like region, for example. Did yours come up yet?
Yep.
Yeah, so yours is starting with age groups. Let's do the same thing on yours.
So we have member months here.
Yep.
This caused it, well, what did you deselect the other day that caused it to, we got 478,000 rows here.
Right, yeah, so we have to go to columns and we have to deselect, I forget which one it was now. Get rid of age category for sure. Which one was it? Oh, was it the encounters, the ER visits?
I think it was these utilization measures.
Yeah.
I'm not sure which was the culprit.
But you can see there's a lot of them that are selected as you go through. And then there's a lot that aren't selected. And region's actually one of the nice cuts, or actually county, right? County for you guys. So hit county, and then maybe, yeah, bring that up to the top. Now let's run that and see what we got. Yeah, it looks like the whole, well, that's not so bad. So now, here's one of the issues, right? You do have a little bit in each of these in the WIO data. You may only want to see Wisconsin, in which case you'd go back to the filter button, and now you'd be selecting only the Wisconsin one based on member geography. There you go. And you can see how it remembers what your column selections were as you go back and forth. And then what we'll do is we'll dive once more, because this is the area where you get that little round go back button. So there's all of your counties, and now you're able to actually see standard cost, PMPM, and you can add any of those metrics that you wanted to add there before. Any questions on overall metrics? Now, you can slice and dice this any way you want, quite frankly, because when you go to the columns, you have a lot of other choices. Now, the one thing that we haven't talked about, and this is something that Sarah and I have talked about, if you're an administrator, you can actually add more columns to this than exist in the view. That's one thing you guys have to work out with WIO, though, because when Sarah adds a column to this that doesn't exist, everybody gets that particular column. And sometimes it's very valuable to use, sometimes only one person needs it. So as an administrator, down under administration, the ability to add computed values, the ability to add columns that don't exist right now when you go to the columns button is there.
And for the most part, we've enabled just about every column that would be relevant.
Yep.
I can't think of any that we don't expose through that
Right.
columns button.
Yeah. And the way to tell what columns, again, and you can't do it here, but if you go back to the filter, the way to tell what columns may be available, that may be of interest, is to go over to that SQL tab. And if you look in the SQL tab, that table right there has all the columns that are possible to show up. And if you go to the Data Mart Guide, that's where you'll find the column names and the glossary and the description of everything that's in there. But again, you need to work through Sarah to actually make any changes there. Okay, so let's go on to cost and use, and let's do trending next. There we go. And again, you can see the filters changed a little bit, and you have the custom tab as well as the regular. You can just submit if you want, Sarah, because I just want to do one thing to show folks how the back button works. Okay, so far we've been only using the back button up at the application, at the Internet Explorer level. If we were to click on any one of these links here, this is going to bring you to additional data based on that particular age group in this case. So go ahead and click that link, and it's going to bring you to a set of links. This is more information on it. You see this little back button there? That's the one you want to use if it shows up, because it's going to remember what you were doing before. If not, if you just go back, it's not likely to remember what you're doing. And so what happens here is after you get this all set up, you can drill down into that, and here's where you get your quarterly look at what's going on. So here's where you can start to do trending. And you can trend that, in this case here, it's just member months, but if you wanted to trend on type of service, you could do that, and you can go all the way to type of service level 3. It's not down to the CPT code level here. You can't get there from here. In the online cubes, when we get there this afternoon, you can go down to that particular level. So in this particular case, ancillary facility, inpatient, outpatient, pharmacy and facility services, you've got all the quarters out there. And again, for any of these, you got the columns button, you can go and sort that out. But if Sarah goes to level 2, each of these are going to expand out again.
Slow today.
I know, I don't get it. It's this morning it was...
Hardware edit.
Yeah.
Maybe. No, you know, this particular case, I think it's the internet connection coming into here. And that's only because both systems are this way. So here you can see ancillary is actually blown out to the individual ones, and all the quarters and the PMPMs are actually taken at that level. Now, if you wanted to find out at this level here, what is the total standard cost for the quarter, what's the highest, you could actually click on the columns themselves and it'll resort that on the columns. So no matter where you are in the quick lists, things to remember, you can sort every column. You can add and subtract columns. You can use the filter button. You can go ahead and save any of the reports that you have here. So in this case here, facility inpatient, no surprise. Any questions? No? Okay, so let's take a look at a couple of the other cost and use reports there, and then I'm going to do slides for the remainder. So this was trending. This is just straight cost and use. We can do it by specialty, facility, and pharmacy. We haven't spent a whole lot of time in either facility or pharmacy, and so let's jump into one of those and see what we can see. So again, you know, these are pretty generic categories now. Yep, and Sarah's just going to go filter it by Wisconsin. Yep. And since we've picked pharmacy, this is an opportunity to talk a little bit about people who have pharmacy and people who don't have pharmacy and how we compare physicians on that particular level. When we look at physicians and you're looking at their resource utilization, if people don't have a pharmacy benefit and the physician has a lot of those folks on either their panel or the episodes they're treating, compared to another physician whose folks almost all have the pharmacy benefit, how do you think the physician with the pharmacy benefits folks is going to look as compared to the physician with no pharmacy benefits on his panel? He's going to look high, right? Lots of resource utilization because drugs is a big part of it. So what we do in the tool is there's a marker in the tool to indicate do they have pharmacy coverage or don't they have pharmacy coverage. And we actually take that into account during the risk scoring. So for example, we know those severity levels that we saw down there, and when we start computing actual cost versus expected cost, we tease out those with and without pharmacy. Now, that doesn't cover the folks that go to Walgreens and pay $4. They have pharmacy coverage, they just ignored it. So that doesn't count for that at all. So if you've got an area of Wisconsin and you know that all of a sudden you've seen a dramatic drop-off in some of these drugs that Walgreens just put on the list, you know that that's going to affect this. But there's no way we can know that in the tool. So you have to have that in your head. You have to have that local knowledge there. So pharmacy quick list, and in this case here, you're getting things that are specific to the pharmacy. Cost per prescription, bill per prescription, days supplied, etc. We also have a link here. You don't have to group it by age. You can actually cut this differently. And let's cut this by, I guess, county this time, Sarah. Get rid of that. Do we have county, or is that the, yeah, that's the right word, county. And that pharmacy benefit status flag, that's where they have where they don't have pharmacy. That's where you'd see that flag. Yep. So now you're comparing all of your counties. You got your member months. and standard cost PMPM here. So if you were to look at this, you can actually see that there is a broad range, but yep, Sarah's just clicked on it, perfect. We're gonna get the best to the worst or the worst to the best, depending on which way the sort went. So here we go for the best county, it's Vernon, lots of patients, about $40 PMPM, and you can see there's a wide range going down. You have 59 rows, so if you, yep, flip to the last one, goes from $40 PMPM all the way up to $88 PMPM. So it's more than double in difference. And you know, this particular county here has about the same population in terms of member months. We had 188,000 versus 193. So now the question is, why? So that's where you have to start digging. Now, if you want to dig into this a little deeper, like for example, this $88 one, you could click the link button, and it's going to dive into this particular county, and we're going to see what makes up that $88. And here's where we have the different levels that you can actually drop to. And Sarah just clicked on the PMPM again. Central nervous system agents. I think we're seeing what we saw the other day in a different way. So if we were actually to drill out on this a little bit more, I think we're down to the categories that we saw before. And if you were to compare this county with that other county at the top of the list, and that didn't come up at the top of the list on the other one, now you're going to have to start to, why? What's the difference in these two counties? Is it the population that's different? Is it the doctors that are different? Who is prescribing these particular drugs? And why are they prescribing them? Antipsychotics. Is that the one at the top, Sarah?
Yep.
Yeah, antipsychotics is right at the top of the list. So you have a digging or a fishing expedition to go on here with antipsychotics, right? Looks like for this particular county, they're really high on the list. Why? And if we go to the other county and just do a comparison, just using the front end of the tool, and that doesn't show up high, the real question is what's going on? Who's prescribing them? What kind of diseases do they have? So I'd start looking at what diseases use antipsychotics.
Bipolar disorder.
Yep.
Schizophrenia.
Yep. So look at episodes. What are the prevalence of episodes of bipolar and schizophrenia in this county versus the other county, and why is that so? So you might be able to do something with some of these numbers, and you might be able to actually cut that back. If it turns out that these antipsychotics are being prescribed in Oneida County by the PCPs, like candy, but in the other county, it's only by mental health providers, wow, something you can do about that, right? So I think when you start to look at the data and you start to drill down on it, when you come up with your questions, then the next thing is, what do I do about it? And I told Sarah this, and we talked about it yesterday. People who have this tool do lots of reporting on the tool, but if they don't ever do something, you never get the savings. So one of the things, you know, lean on WEO. They have great ideas. WEO will lean on us. We've got some good ideas. How do you actually take action on something like this? And what's the outcomes on it? We can tell you that, you know, using this tool in Pennsylvania, they actually took action on some of these. They actually used the doctor lists. They actually pushed those doctor lists out to the actual PCPs, and they decreased their cardiac costs. They decreased their gastro costs by simply referring patients to doctors who were efficient. And they gave part of the cut back to the doctors. In other words, they did a P for P in terms of savings. So when you're looking at the data, it's great to see it, but do something with it. Let's see. So that was pharmacy. Any questions on the pharmacy area? Any questions, I guess, in general on all or any of the quick lists that we covered this morning? No? Okay, because next I think we should do, and I missed it, the Bucky Badger report. I totally missed the Bucky Badger report. So the next thing we're going to do is we're going to actually go off and we're going to generate this templated report that comes with the system, and we're going to show you exactly how you can filter that for certain characteristics. It's not totally configurable, but it's almost configurable. So if you go provider network assessment profiles, and you want to compare any one of these physicians, let's say a specialty physician.
Group or individual?
Whichever one you want.
Here's where I'll put the plug in for the P report user ID. So you all have your own user IDs to log into Impact Intelligence. There's also a login called P report that is accessible to everybody, and that will allow you to do essentially what we're about to do, but really draw upon templates that have already been predefined with ETGs and quality rules already chosen for you. You don't have to go through the process that we're about to go through to set up your report. And we made that available for consistency so that when one organization uses that report sign-on, it produces the same results as if someone else at a different organization producing that same profile report. And the public reporting reports that are going to be published next year on our consumer site are based on this Bucky Badger report and the templates that are available using the P report login.
Yeah, so what we're going to do now is develop a template. In this case here, we picked a specialist peer definition, so we can come in and we can pick any one we want. And again, these are set up for WEO. Gastro's fine, yep. And the next thing we want to do is we want to go and look at what report sections do we want to produce. So in this case here, the Bucky Badger report has a series of sections in that report. Include patterns of care, include case mix, include panel morbidity. And as you scroll down, you can see there's a check mark next to most of them, except as towards the end, we get to include patient satisfaction is unchecked, include member quality non-compliance are unchecked. Well, this can't apply to WEO because the members are all masked anyway. So even if we were to put them on a list, nobody's going to know who they are. So you always leave that unchecked, and you don't have patient satisfaction. Therefore, that's unchecked. So those are the sections that we're going to be using in terms of. We can also look at patterns of care or cost and utilization. And again, you guys are able to actually configure certain areas of that. So in this case here, there's some configuring that can be done, so you can actually take out any of these that you can see here, or you can actually add in a couple of these other ones here. I don't think there's anything on the next one that you can actually change, but go ahead. Oh, actual cost, that's the only one. We'll leave that.
Well, sorry, I'm not able to get that one. How do you get there?
Okay.
We're in the WEO site right now?
We're in the WEO site right now. Yep, and we can probably get to that point. Oh, no, there's two different ones. Never mind. Yeah, no, 2.1 versus 1.3. That's why you won't see that in the demo site. It's slightly different. So now we can do filtering. And here's where the rubber meets the road, if you want to call it that. Here's where we actually get to select specific quality rules that we want to show that doctor and say, hey, doc, here's the rules we want you to be concentrating on, and here's how you are against your peers. So we picked gastroenterology. So I'd go down to the gastroenterology rules here, and I'd say, okay, what rules are available? And there's not very many, but as we look, we can pick up to 30 of them that we want that particular doc to focus in on. So as you look at these that are sitting in here, one of the things you're going to want to consider is, does it require a lab value? If it does, don't bother because it's not going to have anything in there. If it requires prescriptions, and here you have your prescriptions, you can actually check some of those off. So you can check up to 30 of these that you want to actually show up on the report and compare the physician against his peers on.
I'm going to choose all of them.
Yeah, that's fine. There's less than 30. And then the next thing is to look at either cost and use or episode families. I generally leave the cost and use categories the same, but you can pick as many as you want or as few as you want. Episodes, on the other hand, I generally always pick. So these are, you wouldn't pick episodes in cardiology for gastroenterologists. So we go into gastroenterology and we can pick 8 episodes. Now, how do you choose? Well, there's way more than 8 here. So Sarah can't just say, grab them all, right? For each one of the episodes that you pick here, you're going to be measuring that provider in the report against all his peers for doing the episodes. Generally, you pick the high volume episodes here. So, first question in your head is, oh, how do I know which ones are high volume, right? Well, one of the ways to tell is you can get those same episodes of care. Remember we did the quick list and we did episodes? And you can actually find out how many of those episodes exist. Or you could actually just go out and talk to your CMO, and the CMO off the top of his head can tell you which ones he wants. So Sarah's picked a bunch of good ones, I'm sure. And we're going to apply that.
So here, I want to make mention of a thing that I think is often misunderstood, and that is the reports that display, the things that display on the report as opposed to the measures that go into the actual indexes.
Yep.
So I just picked a handful, 6 or 7 ETG families. It's possible that I picked one that isn't part of the peer group.
Yep.
If we had gone into cardiology and selected ischemic heart disease, it'll be included if there are any episodes
Mhm.
for that peer group. And so this configuration document that we keep alluding to has all of the ETGs that are included in every index calculation. The other thing that I want to make mention is when you actually look at the Bucky Badger report, you see the summarized data, you see a subset of what is going into those indexes. We've picked 30 rules and 8 ETG families, but it's many more than that that actually
Go
make
into
up
that index.
the indexes.
Yep. So any episode that gets attributed to a physician, whether or not Sarah picked it here or not, goes into that episode, goes into that index that you saw. Remember the index that said episode and it was like 1.0 was standard. If you were less than 1.0, you were efficient. If you're more than 1.0, you're not efficient. Every episode that gets attributed to a doc that's complete, that's not a low outlier, will be forced into that. Here, we're only looking at specific types of ETGs. So now, what we've got is, we've got the peer definition, and we've got a bunch of information going over there. So what I usually like to do for demo purposes is pick a really bad physician, because then you're going to be able to see where you can take action or what you can tell that particular physician.
We're
So,
actually looking at affiliation level 1. We're going to want to add a column.
yep.
And I'm adding, because we're in the WEO data, I'm adding affiliation description level
Yep.
3, which is the group practice level.
Yeah, and you might want to get rid of population because that's going to be useless to us.
Right.
And we might want to add in, yep, you got it. Okay. Oh, that's okay. We'll just leave it there. Just go to the right. What we're just going to sort on is we're going to sort on the index to find a really bad physician. So you've got the standard index over there on the far right that Sarah's going to sort on. And we've got the really good physicians first, then we've got the really bad physicians. One of the things we didn't do here is this number of episodes is going to be a problem, but we have this one doc right down here with 1,068 that's got a case mix that's fairly high. So let's see if that particular doc is any good. Oh, that particular doc is definitely 44% higher in utilization. So we're going to pick that one, and we're going to run that one. And the reason I picked a bad doc here is because I really want to show you how you can fine-tune and tell the doc, hey, it's your ER utilization. Hey, it's your inpatient. Hey, it's your outpatient. Specifically say why you're different than your peers.
Do I have to save this before I run it?
Yeah. In the new version, Sarah just asked, do I have to save it before I run it? In the new version, 2.1, you'll be able to just do it and it'll run right on the screen. Now what we have to do is we have to save it, run it, and it's going to appear under download reports here when we're done. Ah. Oh, down below, yeah, there you go. There we go, and we'll submit it now. And what generally happens is when you submit this, you can see it says an email is going to be sent to Sarah as soon as it's done. It also gives you when it's likely to be done. It's likely, and this is my calendar, by the way, so it's 2 minutes away. I'm on East Coast time. My computer doesn't change. So at 12:01, this should be done. And where it'll appear is it'll appear in download reports. So if you go to download reports, Sarah, there's one report probably from yesterday in there. Oh, I'm sorry, we're under you. We're logged in under you. There's a ton of reports in there. And basically what it gives you is it gives you, what it is, it gives you the time, and it gives you the date. So you can actually see that particular one. So that should appear in just about a couple of minutes. Then we'll go back and we'll find it, and then we'll show you what that particular gastroenterology report looks like. While we're waiting for that, let me mention an area of the application that nobody seems to like, but we'll talk about it anyway. If you go to Provider Network Assessment, and you pick any one, physician episode, physician population, yep, do any one of those. And we're going to be able to pick a peer definition. And since we did pick episode, yeah, we can pick one of the specialties. And you think you're going to get something really great out of this. You kind of do, but it's not very useful. So it's going off and it's kind of computing for otolaryngology, a great RID. There we go. What does this grid show us? It basically takes the overall cost index, remember that index we were talking about, plus or minus 1, the overall quality index, and plots every doctor that's an otolaryngologist on this graph. So if you're looking at this graph, quality, right, if you're above 1 in quality, that means you're good. So you want to be at least to the right side of that particular graph. In terms of cost, you want to be less than 1. So if you're in this quadrant right here, you're a highly efficient doctor. If you happen to be in this quadrant on the upper left, wow, you're a highly inefficient doc. Now the problem is I can hover over those dots to my heart's extent and they don't tell me anything. And that's why everybody hates this. Because if it hovered and it told you who the doc was, it would be perfect. So we are working on fixing these. But nobody at this point goes into these sections and uses these for much except to say, yeah, I've got good and bad docs. And that's what it tells you. What I typically do is you can do this exact same index over index report by going up to provider network assessment and just laying out all the indexes for otolaryngology, dumping it into Excel, graphing the same thing, and be able to hover right over it and see who the doc is. So that's the way most folks are doing it nowadays. So what time is it? It's 12:02. We probably have that report ready. What's today? The 17th?
Here we go.
You found it? Okay. Yep. So this is the Bucky Badger report, except for a real group. It gives you the affiliation ID. It gives you who it is. There's 15 providers in the group, 1,068 episodes. The case is pretty severe, so it's pretty sick. The peer group has 42,266 in it, which is a big number. So we're comparing 1,000, which is statistically relevant, against 42,000. Again, very relevant. And they don't form the big bulk of that either, which is really important. So then we come down, we look at the quality index is great. 10% high quality. Their cost index is 40% higher. They're both statistically significant. So now we can actually say something about this, and we can actually go talk to this group. What it first does is it comes up with the top 10 ETGs by total cost, and these are just the top 10. These aren't the ones Sarah picked earlier. These are the top 10, right? So here's another way to figure out, oh, geez, I really should have picked inflammatory bowel disease, cirrhosis, and in fact, maybe we didn't pick those. But anyway, 286 episodes, 107. Here's the actual cost. Here's the peer cost. What do you see there? The actual cost is $6,000, $7,000 higher than the peer cost for inflammatory bowel disease. It's higher for cirrhosis. It's lower for hepatitis. It's about the same for inflammation of esophagus. It's higher for ulcer. So you can kind of get a picture of what's going on. You also want to look at the other side, the encounters there. They are higher in cost per episode. They're also higher in encounters. So they're doing more encounters and their costs are higher. And you can see across the board there, it kind of reflects what's going on. This doesn't kind of tell you what the doc's doing different though, right? This just says, okay, here's the things, I am different, my costs are different. As we roll our way up, this is just the relative morbidity of the case mix across the peer groups. Keep going. We're going to get to, keep going. I want to get to the rubber meets the road right there. This one here tells you where the doc should be focusing. So his peers use 24% less ER. His peers use 22% less hospital, 79% less laboratory, 32% less pharmacy. Basically, across the board, these guys use services up the gazoo. Now, I don't know if you guys recognize who this clinic is, but these guys use services. And if you come down here, those services are broken out in profile cost there versus actual cost, and you can actually then see the utilization here. I look at this now and I simply say, you guys use everything more than anybody. And that's just a bad thing. Normally what you get is you get a few above the line and a few below the line, and you can actually focus in on it.
Medical College of Wisconsin is a teaching hospital.
Ah! See, you know it. I don't know that. So that's why they use everything. And so let's these are what Sarah picked. She picked each one of these, and now they've got 134 episodes. And so for each one of these, you can actually see by primary service category, specialty, lab, radiology, hospital, pharmacy, ER, whether they're higher or lower. Well, you know, it's interesting for this particular one, their lab is actually lower. They're lower in hospitalization as well. So for this particular one, inflammation of the esophagus, they're not as bad even though they're a teaching hospital. But they do have some improvement in terms of ER and in terms of specialty care. So what does specialty care tell me? Well, these are specialists, right? That tells me they're using their services, their own services, more than other gastroenterologists are. Could this be a case where, hey, we'll see you in a couple weeks just to see how you're doing, and they continually do that, right? Might be, but it's a teaching hospital, so that's very likely. So those are the kinds of things you look for when you look at this particular report. I don't particularly pay a lot of attention to the ER column because patients show up to the ER. Like, for example, if I felt like my esophagus was burning, I'm not likely to call up my gastroenterologist and say, can I make an office visit in 6 weeks, right? I'm just gonna go. So we don't really gig people in this particular area, but certainly when it comes to pharmacy, specialty care, primary care, again, you don't concern yourself with here because specialists don't refer back to primary care very often. So you pick and choose what you want. Inflammatory bowel disease here, it looks like across the board, they're horrible.
That was that top.
Yeah, that was the top one, yep. And you can see for just that one, look at it. 1.5, 1.8, 1.3 times higher than anybody. So that's something to consider. And she picked hernias, and in this case here, there's only 4, so we won't even consider that. Yeah, so I won't even look at the rest of that. Yep,
They are higher after adjustment for risk.
yep.
Regarding the ER, is there any way to look at ambulatory care sensitive issues here?
Ambulatory care sensitive conditions, right? I have other clients that have done that, yes. We can't do it in this particular Bucky Badger report at all. The Bucky Badger is not designed for that.
Wait, but
Yeah, yeah. We have 2 clients that actually did that, and they also did avoidable ER and avoidable inpatient, and they run reports on it based on the data that's in the system. But the thing with the avoidable ones, or each state seems to have their own idea of quote what's avoidable, and I might go so far as to say that in the Medicaid population, it's sometimes different than the commercial population. So you guys make that decision, and generally speaking, what we end up doing is we end up creating a SQL statement that goes against the data mart that pulls that out and gets the list. And what you do is you maintain a table of what you consider in this state to be avoidable. And then what ends up happening is, let's say you have a bunch of avoidable ERs. Well, in most cases, the primary care physician doesn't find out about the ER visit, right? But you have the ability to tell the ER or to tell the primary care physician. So my other clients, they take that list every month and they ship it to the imputed PCP and say, did you know your patient was in the hospital for X, Y, and Z? And they actually incent the docs to keep them out of the hospital for those. So do you want to go back to the quality measures? I think that was up towards the top.
Yep.
There we go. So here's where we picked every quality measure for gastroenterology. And what we're looking at here is we're looking at the quality index, we're looking at the rates, and we're looking at with compliance and not. You can see that all of their rates here are high for a teaching hospital. I think that's appropriate, to be quite frank. So they're doing a great job quality, but they're also costing a fortune. So the question is, what's good enough quality for this? They're better than their peers, sure, but if they're still fulfilling their mission and costing more money, then what do you do about that? And I guess that's, again, where the rubber meets the road. What do you do about this? But you can see all the ones that are picked, and I don't think there's one that's less than 1, is there? Nah. So they're good in everything. Now, if you knew the members here, you could actually identify the members that were non-compliant, and on the same Bucky Badger report, give the doc a list of those particular members that were non-compliant. Any questions? The Bucky Badger report, yep.
Can you talk again one more time? I know you did, and I'm a little confused about this, how the severity plays into it, and because I know at the top there's the risk
Yep.
adjustment.
Yep. Sure. Let me use the board to do that, and I'll kind of detail out maybe one case of how physician A in a gastroenterology group gets compared to all of the other physicians and gets severity adjusted.
Because like this case mix episode is way higher, right?
1.44, right. And his case mix is 1.79. A case mix is 179, his index
Yeah.
is 1.44, right. Yep, yep, we
So, I
can,
mean,
we can do
could
it.
that
Yep.
be explaining why the cost is so much more?
That's all taken into account in the index.
What about the quality? Same thing?
No, quality is a separate thing. It's not meshed with the utilization. Quality is a separate index, sits out there all by itself.
So if in their case, their quality is better, but let's say their quality was worse.
Mhm.
One could make the argument that it's because they really do have sicker patients, right? Because
Quality-wise, there's two schools of thought that I've heard. Unless you're a hospice patient, you should be getting the quality measures that you deserve. Like, for example, if you're a cancer patient and you're like on your last legs, don't even worry about the quality measures. That person's got way more to worry about than that, right? But if you're just an average gastroenterology patient with perhaps an ulcer, there's absolutely no reason you shouldn't be getting all of these measures done, right? No matter who you are. So that's one school of thought. The other school of thought is that you lead with quality. In this case here, you guys are doing a great job in quality. We really got to work on your cost. But in this case, they're a teaching hospital, so there's not a lot you're going to do about this because they like these repetitive visits to teach people. But if this was a regular group, then you'd go in there and you'd say, you know, one of the issues is here, you are great in quality, and we really appreciate that. Your costs are outrageously high, 50%, 44% higher than your peers. Let's figure out what we can do to get those down and keep your quality high. So do you still want to do the risk thing? Because I can actually work that if you want.
So, just to be clear
Yep.
that I understand, the risk, the case mix
Yep.
is factored into the cost. It's not factored into quality. It's factored into.
That's right. Quality is, you should have had this done. You either did or did not. Has nothing to do with risk. Oh, so that was the question. Okay, then we're
I
good.
think I've.
Okay,
yeah,
that's
that
good.
helps.
Yeah. Yeah. Now, what we do is we do mix quality measures, but that's totally appropriate. And by mix, I mean we don't go and say, okay, for a PCP, you can't have the reverse. What we say is for a PCP, you can have quality measures in cardiology, in endocrinology, in gastroenterology. So PCP is responsible for everything, right? But then when we go to cardiology, that same measure that the PCP was being held responsible for, the cardiologist is being held responsible for at the same time. So for example, hypertension. If you should be taking your hypertensives, your PCP is being held responsible and the cardiologist, if you've seen a cardiologist for an episode. Yep. So that's doubled, but at the patient level, it's a single hypertensive episode, and it's a single hypertensive quality. Okay. Okay, so I guess we can drop the Bucky Badger report. And what we're going to go back to is we're going to go back to the slides for a little bit, and we're going to cover some things that are more methodological or procedural, if you will. And then this afternoon, what we'll do is we'll jump back in.
Before we continue, I just wanted to say that we have some snacks now.
Oh.
There's coffee and water and a couple items.
What time
Oh.
is lunch? Do we know what time lunch is coming?
It's around noon, right?
No, it's not noon. It's 11:14. Yeah.
It's
In about an hour or so.
do you want to take a break for a snack?
Yeah, we could do
Want
that.
to take a break?
Sure. Okay, so let's take like 10 or 15 minutes, come back at 11:30, and then we'll go to like quarter after. Okay.